Welcome everybody, and to our November, not November yet, October Health Equity Webinar Series. As many of you know, I'm Lydia Isaac. I'm the Vice President of Health Equity and Policy here at the National Urban League. I'm really excited to have this panel here of just world expertise with us to talk about cancer prevention, treatment, and treatment. And so, as many of you know, this is Breast Cancer Awareness Month. But we intentionally actually decided not to focus just on breast cancer, but to focus on cancer prevention in general. Part of that is because, yes, for women, breast cancer can be the leading cause of death. Actually, it's not the leading cause of death, heart disease is, but it is one of the most, I would say, scariest causes of death for women, and particularly women of color. But we can't also forget that there are other cancers in this world that also have huge impacts on our communities. And so we wanted to take this opportunity during Breast Cancer Awareness Month to focus on the larger issue of cancer prevention and cancer treatment. And so I just wanted to say that, because I know people are wondering, well, it's Breast Cancer Awareness Month. Why are we not doing breast cancer? I think it's important for us to talk largely about cancer prevention in general. And a lot of the things we're going to talk about here also, of course, apply to breast cancer and many other cancers, but just for us to be aware that there's a larger field that we need to think through when we're talking about cancer prevention in our communities. So that being said, I want to introduce our wonderful panelists who I'm so excited to have here, who really are just I'm so grateful that they took the time to spend with us. So first we have Dr. Kimlin Tam Ashing, who is a professor in the Department of Population Sciences at Beckman Research Institute of City of Hope. You all have her bio, so I'm not going to go through the whole thing. We also have Dr. Wayne Loris, who is the research fellow at the National Cancer Institute, Division of Cancer Epidemiology and Genetics. And I will say my dear friend, who I sit on a panel with, Shelley Nasso, who is the Chief Executive Officer of the National Coalition for Cancer Survivorship. So welcome everybody. Thank you so much for being here. I'm just going to start off with our first question to the panel, and anybody can take this. And all of you can take it, or any of you can take it, is, what are some of the inequities in cancer prevention, screening, and outcomes that Black Americans face?
I can start this off. Throughout the entire cancer care continuum, from prevention all the way to survivorship, Black individuals receive poorer care and have lower health outcomes. So we know that compared to white individuals, Black individuals are more likely to experience barriers to cancer screening, more likely to experience delay in initiating screening following a positive cancer diagnosis, less likely to receive guideline and recommended treatment. This is most notable for Black women when it comes to breast cancer, and less likely to receive the full treatment when it comes to adjuvant therapy, which we know is supposed to reduce the chances of cancer reoccurring or cancer coming back. So from prevention all the way to outcomes and then post-cancer treatment, we know that Black individuals continue to experience poorer cancer care, which contributes to Black individuals in the United States having one of the highest cancer mortality rates compared with most other racial groups.
I just want to add to that, Dr. Lawrence, that the surveillance is so important. So the access to preventive care and screening, access to diagnostic and therapeutic care, but follow-up care, as he mentioned. In one of my earliest studies, 20% of the Black breast cancer survivors did not receive a mammogram in that year. So they're not getting the follow-up care that they need. And that may be critically important to why we have this disparities in mortality. It's from the whole continuum, including follow-up care, and of course, survivorship as well.
And I would add, we do a survey every year called the State of Cancer Survivorship Survey. And this year was our 5th year. We just released the results earlier this month. And we find that the Black respondents to the survey are less satisfied with their care overall. They feel, not surprisingly, they don't feel as respected by the healthcare system. They don't feel as comfortable sharing with their physician, or knowing that they're feeling like their team has their best interests at heart. One thing I found interesting in our survey this year is that we ask a number of questions about treatment decision-making, how you kind of prioritize factors of treatment or deciding about treatment. And overall in the national sample, and we have a nationally representative sample, people are very deferential to their doctors, but we find that the Black respondents are much less likely to defer to the doctor, more likely to want to be engaged in decision-making about their care and doing the research to really understand what they need to know in order to make decisions about their care.
So I want to talk about this idea of screenings. I think all of you really talked about it and put it up and put it to the forefront. What do people need to know about screenings? I think, there's a lot of information about there, particularly, there's been changes in who should get screened for example, colon cancer, at what age and how. And what would you tell if you had a community member that you were speaking to and saying, when it comes to cancer screenings, what should people be thinking about? What should they be doing? How should be, whether they have cancer in their family or not, how does screening help us to get to cancer survivorship? Because Shelley, I want to talk about this idea of cancer survivorship, because people also think that cancer is a death sentence, and it's not. And so how do we help people to understand the importance of screenings and the fact that you can survive cancer if you get it early enough?
Yeah. I think that's so critically important for our community because, like you said, there's still this belief that cancer is a death sentence, and even for some, stigma. So there's this that bars our screening. So even when we have access to care and coverage, sometimes we're thinking that, oh, if we get screened, we're looking for cancer that's not there. But I think we have to change the languaging, influence the culture that cancer screening does save lives, that early detection makes the cancer much easier to treat, much easier to survive and have, prolonged survivorship, and to treat it as a chronic disease or cured. Many cancers are curable when detected early. Prostate cancer, breast cancer, cervical cancer, colon cancer, these are all curable cancers if we get it very early. And in particular, prostate cancer and cervical and colon cancer, when detected early, well, especially cervical and colon, actually the detection can detect cellular changes before it becomes cancer. So we really can detect pre-cancer conditions. I have started getting my colon cancer screening early at age 35, which I had to advocate for myself because colon cancer runs in my family. Thank God they changed the guidelines to 45, which would catch many more cancers early. But if you know you have a family history, and that's another thing with our community, we need to talk about our health impact, talk about what we have in our family, talk about how Auntie may have died from breast cancer, ovarian cancer. If we keep those things a secret, then we don't know how to advocate for ourselves and to get screening. So these guidelines are guidelines based on the general population. If you have a family history, it's probably in your best interest to start screening earlier. So for example, my father was diagnosed at 40 with colon cancer. That's why I advocated to start getting screened at 35. So know your family history. Cancer is common among all populations, but we suffer more. And let's take action for our health, to know our family history and to get screened early. Cancer screening saves lives.
Dr. Lawrence, I feel like you wanted to say something.
Oh no, everything was addressed. I just want to say that when it comes to my recommendations, I usually say speak with your physician. If you have a family history of cancer, talk to your primary care physician about it. Say, hey, I have a family member that's died from cancer. When should I start screening? Or I would like to discuss ways that I could reduce my risk of developing cancer too. Could there are preventative measures that could be taken? What we know is that Black individuals in the United States are more likely to be diagnosed with cancer at more advanced stages, where treatment is more costly and less effective. So to keep all that in mind, it is best if you could try to talk to someone within your community that works with cancer screening, or speak with your doctor, or look at the American Cancer Society, as they have guidelines as well too. This could all help with reducing I guess, increasing your long-term survival and quality of life as a whole?
Yeah, Dr. Lawrence, I want to go to Shelley on this idea of your quality of life and cancer survivorship, and how important, going back to what Dr. Ashton talked about, of getting it earlier, being able to treat it, and working with cancer survivors. What has been your experience as you see through the continuum of when people get diagnosed, and then their ability to, how they are able to live as a cancer survivor?
Yeah, I think one of the problems is that our system, once you've gotten a cancer diagnosis, we're just so focused on treating the cancer, which is obviously important. But the cancer affects so many aspects of your life. And I don't think that the healthcare system does a good enough job of helping people manage all the other pieces of their life, all the side effects, the long-term effects of cancer treatment, the psychosocial effects, the financial effects. And, one of the things we ask in our survey is for thinking about post-treatment. What are you talking about with your doctor at these post-treatment visits, whether it be your oncologist or primary care? And some people get transitioned back to primary care after a certain amount of time, depending on the type of cancer they had, the amount of risk they have. And sometimes that's really appropriate. And the oncology workforce cannot continue to follow. We have 18 million cancer survivors in this country. There's not enough capacity for oncologists to follow every cancer survivor for the rest of their lives. So some of that has to get transferred back to primary care. And overwhelmingly, we hear from survivors that the focus of those post-treatment visits are on, has the cancer returned, and any surveillance and any testing. And at the same time, survivors are telling us that they're dealing with a lot of health issues as a result of their treatment. They have fatigue, they have mental health effects, even years after their treatment. They have a lot of other physical side effects of their treatment. And, mobility issues, just quality of life issues. They also have a lot of concerns about exercise, nutrition. They know that those have a bearing on cancer and can reduce their risk of recurrence, but they don't really know what to do. And they're not getting, so they rate it high on their list of concerns, but they say they're not necessarily getting the help that they need to address those. But yet they're not talking about it in those post-treatment visits. It's just all about, all right, your scans look good, you're good to go. We'll see you in 6 months, or we'll see you in a year. And so I think, what we really need to move to kind of a more holistic way of treating people, and not just looking at, are those cancer cells gone or have they returned, but like, how has this impacted your life and your ability to function, and how can we help you with it? Because there are things we can do. I mean, for example, rehabilitation is very underused by cancer patients, and it can really help with a lot of the functional limitations people deal with during and after treatment as a result of their treatment. But they don't, and a lot of times their insurance will cover it. They just don't know about it. The doctors don't refer them. It's sort of like this underused resource that could really help people, but people don't know about it. So I would like to see kind of a more holistic way of approaching it, so that we can help people, live better with cancer and after cancer, instead of just focusing only on making sure we kill the cells.
Thank you, Shelley. I really appreciate that. And I think it goes back to what Dr. Ashton said about, cancer screening saves lives, but if it's going to save your life, you want to live a good life. You want to have a good quality of life. And that's what cancer survivorship is about. And so we can save more lives, but we want them to have good lives. So I just want to transition us a little bit to actual treatment, and thinking about what are people's options. And I think it goes to what you were saying, Shelley, about what we can kind of pay for, or what can be supportive of treatment. Why are these barriers happening for, low income, African American, immigrant communities about treatment, getting the right type of treatment? Because they also are expensive. So I just wanted us to talk about the inequities in treatment, and how do we see that happening? How do we find solutions to those inequities?
Well, I want to start. I mean, I'm clearly not a physician, and so, but in my research, in terms of looking at access to quality care and timely care, we develop an intervention called the Treatment Summary and Survivorship Care Plan. Of course, this is for people who are already in the system. We know that there are people who struggle to get access to even diagnostic care. But one of the things that's critically important for survivors would be to understand what are their treatment options. And Shelley indicated that Black folks want to know what are their options, and they're not being told. So we don't have the information. We're not being educated about what the treatment options are. Cancer treatment is very complicated. It involves surgery, chemotherapy, immunotherapy, hormonal therapy, all right? And so folks need a care team that would take the time to explain all of these. And the other important piece, I think, with treatment is now we have precision medicine that could look at what are the genetic genomic risk for that specific person and help tailor the treatment to best treat that cancer with lower side effects. We're not getting referred for genetic and genomic counseling and testing. So we're missing out a huge piece in the advances in medicine that's being paid for primarily with, guess what? Taxpayers' dollars, working people, which include a lot of Black folks, and we're not benefiting from that. So advocacy in terms of within organizations like Shelley's and others, so that we can be prioritized for inclusion in studies that that come up with new treatments and new diagnostics, clinical studies, and also how we are informed about the choices of treatment. And if we, unfortunately hear the word we have cancer, what were the treatments that were offered to us? What were the side effects that we experienced? How would those treatments and treatment plans change to respond to our particular needs? And then in a survivorship care plan, sort of whole person, as we're talking about, whole person care, where consideration for co-occurring chronic illness is also considered. How does the diabetes or the hypertension or the arthritis fit into this? And really looking at care coordination between the primary care provider and the oncology team, and as well as other specialists that the person may need to see, either pre-morbid because they may have had diabetes, or the cancer may have created some other kinds of side effects, as we know cancer treatments can, especially if it's diagnosed at late stages and the treatments are more toxic. So we need all of that. And what are the health advisories? Shelley talked about people want to know what are the nutritional advice, what are the physical activities. They need guidelines and encouragement to do this. And then what are the resources tailored to Black folks in the community or nationally? We rely a lot on web-based resources. So what are those kinds of resources? So we really need that reframing about the whole person care and advocacy so that we could get that whole person care for our community.
Thank you. I very much appreciate that. Dr. Lawrence, I was going to say, I thought we lost your camera, but we didn't. I actually want to take a thread that Dr. Ashing talked about genetic testing and the importance. In our communities, we have a tendency, and I'm gonna out myself in this right now. Just like Dr. Ashing, I have a history. My dad has had colon cancer twice. He's a 3-time cancer survivor, and so we have been very resistant in my family to do the genetic testing. Because of things like, Henrietta Lacks and other things. And so I just want you to talk about the importance. We finally did it. I will say we did it, but it took a lot. It took a lot for us to agree to do that. Particularly, I think we finally agreed because of the next generation, to be honest with you. But I think it's important for people to understand what genetic testing can do. Dr. Ashton started to talk about precision medicine, but also how it can help further generations. So I wanted to just talk a little bit about what genetic testing is, why it's important, and how it can be used.
Sorry about that. My power went off a little bit just now. But yeah, so I must know this is not my area of focus. So I'm gonna broad strokes, but I can say that when it comes to genetic testing or tumor identification, it helps with informing the physician on the types of treatment that would be best for you. How would your response to that treatment would be? So we know that a lot of the times when it comes to access to genetic testing, unfortunately, your neighborhood environment plays a major contributor factor. For example, we know that Black individuals of lower socioeconomic status resides in neighborhoods that have less accessibility to cancer specialists to see a physician with limited resources to provide clinical resources to that a patient that they may need. So as important as treatment is, we also must take into account that the neighborhood environment may play involved when it comes to access to care, including access to genetic testing and the role that the physician may have when it comes to advocating for these sources or where to direct the patient to these sources for care.
Shelley, you want to talk a little bit about genetic testing?
I mean, I would just say one thing that's so important is the counseling piece of it, because that's really the first step before you get to the testing, because I think sometimes it can be really overwhelming and it may go towards, you know, your family's reluctance is like, well, what do we do with this information? And, you know, if you test positive for a certain type of genetic predisposition, what does that mean? How do you screen for it? How does that help you going forward? And I think the genetic counseling can help you really figure out like if it's right for you and how you would deal with those results, and then they help you deal with the results when you get them. And I think that's a really critically important piece of it, that, you know, it's not like you're just going to get going to get a test and then left to your own devices to deal with the results. You need that counseling to help really understand, because, you know, some of these, you know, like Lynch syndrome, I mean, that affects multiple different types of cancer. So there might be multiple different types of surveillance you have to do that are different from if you didn't have that. But, and I think people, you know, maybe know more about some of the other genetic, you know, genetic mutations like BRCA, you know, and we know that that's associated with breast and ovarian cancer, but, you know, there's more that are being discovered and that affect, you know, families in different ways. So I think that counseling piece is just what's so important, but it's also, again, it's the access to it that Dr. Lawrence mentioned that's so critically important.
I just want to
go ahead, Dr. Ashton.
So it's not my area of expertise, but certainly an area of personal relevance because I have a strong family history. So there are multiple levels of disparities when it comes to genetics and genomics. You know, one is that we're not informed about the possibility of a genetic test. Even when we share with the doctors that we have a strong family history, they may not recommend it. So again, advocating for ourselves, saying, is there a genetic test that's available for me that can help me in terms of prevention or risk reduction? You know, Shelley mentioned Lynch syndrome, which is related to several cancers, especially colon cancer. And the other thing is, if we don't have access, and
can we just say what Lynch syndrome is? Sorry, can we just say what Lynch syndrome is?
So it's a genetic mutation that's very common in many cancers, including colorectal cancer. So it was first sort of associated with colorectal cancer primarily, but it's now, you know, become associated with other kinds of cancers as well. And there is a genetic test for it. So one of the things is that we get, including myself, get results of unknown significance, which means that it's suspicious, it's probably not normal, and it's related to some cancer, but we don't know what. And part of it is because we're not included in those studies. So if we are not included, we're not going to get the clarity that other populations get in terms of what their risks are. The other thing, so these are just, you know, general genetic tests. In terms of when we have a cancer diagnosis, in terms of precision medicine, we're also not informed that there are genomic tests that could be done called somatic testing. They could actually test the tumor, right, to find out what are the mutations in this specific tumor that could help guide the drugs and the medicine to treat that cancer more efficiently with less side effects. If we don't get these tests, then we're not getting the best treatment for us. And so really advocating for our community, if we have a cancer diagnosis, oftentimes those samples from the biopsy and the surgery are kept. It could be done afterwards. And it may or may not help the patient, but it could also help in future generations, because like you said, that could also inform whether other family members should get tested as well. So advocacy and educating the community and, you know, going to those doctors and saying, I heard about this. Can you tell me more about how this new advances in precision medicine, in genomic testing, how can that help me survive better and have a better quality of life?
Shelley, looked like you wanted to say something, but I wasn't
No.
sure.
No.
Okay, so and I want to add to that point, and Dr. Ashton, you brought me into my next question, but also that many insurances cover that, particularly if you have a diagnosis, but even if you don't have a diagnosis. But I want to go to another thread that was discussed about clinical trials. We know, Dr. Ashton, you just kind of mentioned that, you know, because African Americans in particular, or Black Americans in particular, do not sometimes get genetic testing and or in clinical trials, it's hard to have comparisons as to what to compare and know what's going on in that community. And as Dr. Lawrence said, because also you have the epigenetic component, which is the environment impacting the genes, that can impact your genes. Why do we see this low number of African Americans participating in clinical trials? And how do you think we increase that number? And in particular, I want to talk about why clinical trials are so important and for having diverse representation in clinical trials. Anybody can take it.
Well, I'll start with stress. Yeah, I mean, but I wanted to mention, and I would love to hear Dr. Ashing and Dr. Lawrence's response on this. But Dr. Joseph Unger from Fred Hutch Cancer Center has published a meta-analysis of a bunch of different, looking at clinical trial participation, and they concluded in this meta-analysis that the biggest factor was being asked. And they're really, when a patient is asked to participate, there weren't differences. And in fact, in some cases, Black patients were more likely to participate than whites. It's just that they're not being asked. So they said what we really need to focus on is the structural problems with the clinical trial system, because if you're not getting to an institution that offers trials, or a clinician that does, or if the clinician decides not to offer to you because they don't think you're going to want to participate, then you don't have the option. So I'm interested, I'm not an expert on those structural barriers. I know about them a little bit, but I'm really interested in Dr. Ashing and Dr. Lawrence's perspectives on that.
Yeah,
Go ahead, Dr.
Sorry, let's go. Yeah. So there are a range of structural and injustices when it comes to diversity in clinical trials, where we know that clinical trials help identify new treatments that are safe and effective for everyone. So we want diversity because we want it to be effective for everyone. So when we look on the individual level, we know that, as mentioned earlier, Black patients mentioned that the healthcare provider never informed them of clinical trials. However, we also know that patients reported barriers due to lack of awareness of clinical trials. Medical mistrust is a major part when it comes to wanting to engage in clinical trials. But we cannot ignore the role of financial barriers, such as cost of transportation to the clinical trial center, as they're not often within the community. Childcare, clinical trials are usually time consuming, and childcare is another barrier that's been mentioned, as well as lost work hours. People might be working while they're going through cancer treatment, so they can't afford to lose work as well as inadequate or incomplete lack of insurance. Insurance is another part that comes into play when it comes to participation in clinical trials. So yes, it's good to inform them, but we also must take into account the constraints that participants or the barriers they may encounter when it comes to their ability to participate in clinical trials, which includes both time and money, which should also be addressed. Oh, you're muted.
Discussing multiple intersecting factors, right? The societal determinants of health or social determinants of health, I think is so critically important. We talk about sort of what are the risk factors, right, for cancer and cancer outcomes. And of course, we know cancer ultimately it's a genetic disease, whether it comes from the societal determinants or a family hereditary. But it only accounts for, hereditary cancer only accounts for about 10% of cancer. There are other factors that contribute to cancer risk. Lifestyle is one of them, access to care, segregation, discrimination, all of these factors contribute to our risk. They're hard to study and measure because we don't know, how these societal determinants really influence our biology, how it influences our immune system, how it weighs on us. There's, much in the community about sick and tired of being sick and tired. So these day-to-day distress and stresses of discrimination and segregation and living in communities that were slated for deprivation, we know about redlining, and the effects of redlining still continue. as we see in many of our communities. So we talk about sort of ZNA, zip code, as being a major influencer of cancer outcomes. And the CNA, which is the access to care. But those are intertwined, because if we live in a community that has a great distance for a comprehensive cancer center, such as City of Hope, where I am, that distance, as Dr. Lawrence mentioned, is going to impact their access to care. Insurance and coverage is very, very complex. So we need to, focus on how we can have legislation, voting, and prioritization for cancer care. And it's going to seriously benefit our Black community, who are the most burdened by cancer. Even for cancers where we have lower incidence, we have higher mortality. And so we need to really focus on leveraging our voting, our voice, joining with other organizations who could help train advocates on legislative and changing policies, including, clinical trials policies, coverage for clinical trials. One should not have to pay for the test that's done in a clinical trial. All of these things should be covered. So, really focusing on how we can advocate for those things, and that we know that there are protections now in clinical studies. And I really want to change the nomenclature. Trial is never a positive term in our community, in our society, in any way. So clinical studies, these are now clearly regulated. I participate in studies on diagnostic because I want to understand my risk for colon cancer. I'm concerned about it. So I take an active approach and participate in studies of genetic testing because I want to understand. And if we can really focus on how to work with our community to and work with the scientific community, work with the medical community, with local hospitals, because it has to do with trustworthiness. We have not done right by our community, but making small steps with cancer centers, such as City of Hope or other cancer centers who have strong community engagement, and helping to our community to access important clinical studies so that it can improve the prevention, diagnosis, and treatment of cancers, and to be more responsive to the aggressiveness that we see in our community with our cancers. We have cancers that grow very quickly. And these may be epigenetic in terms of environmental exposure. It could be toxins, or it could be, lifestyle, smoking or alcohol. But we need to participate in those studies that can help us, come up with better treatments and also better prevention for our community.
No, that's wonderful. I mean, I feel like Dr. Ashley, you keep on bringing me to the next question, which I love, which is, what are some of the tools, possibly education or outreach, that we think will help us to reduce the disparities and inequities, not only in treatment, but in prevention and in outcomes? Do we, particularly at City of Hope and, at NCI, are we seeing promising practices? And on the advocacy side, Shelley, are we seeing promising policies that can be enacted to help us reduce these inequities?
I guess I can start off. First thing I want to say that when it comes to like disparities or racial differences in cancer death rates and so on, these are primarily preventable and systemic. So what I've seen that have come out of funded studies from my institution is that there are people that have established mammography bans, which goes into areas within their community that have disproportionately higher rates of cancer, which target populations that have higher cancer mortality rates or lower cancer screening rates. We've seen other studies that have used barbershops to increase colorectal cancer screening and prostate cancer screening among Black men, particularly in areas where death rates are substantially higher compared to both the local region and nationally. So there are various strategies now that are targeting well, I focus my work focuses on the Black population, but targets populations that are at specifically greater risk. And what I like about all these strategies is that they are not asking people to come to them, but they are going to the people. They're going to the people to make sure that they have access to these resources, that is on their time and is not on their dime. So, oh, that rhymes. So that's one thing that I like about these strategies that are currently ongoing.
I want to add to that, bringing in the voice, as Shelley knows so well, bringing in the voice of the community, because the community has wisdom about how to best approach the community, how to best engage the community. So looking to community health leaders would be so critically important to be effective in our Black community and any minoritized community. Policy, again, is so very, very important. And how we can help train advocates on policy and making the vote, making legislative action benefit our population. For example, in California, I'm fortunate to live in a state that's forward thinking. We recognize that those who get treated at comprehensive cancer centers do better in terms of survival as well as quality of life. And those who are treated at community centers have less resources. I mean, that unfortunately is the reality. And so City of Hope with other partners, American Cancer Society and other cancer centers, work with the legislation to develop what we call SB 987. It's the Cancer Care Equity Act. And it allows for those with complex cancer centers who are covered by Medi-Cal to access care at comprehensive cancer centers. Now, as you know, health systems and health coverage are very powerful. It got watered down. So we wanted access for any cancer, but it became a complex cancer. So it has to be like, a stage 4 or metastatic disease, or if you have had first-line treatment and that's failed, it allows you to petition. And the process is a bit burdensome. I just talked to a patient yesterday. So you have to petition your insurers to activate this law. So we're working diligently with advocacy community to educate clinicians and policymakers and clinicians and patients that this law exists and it can help patients who are on Medi-Cal to access care at comprehensive cancer centers. So legislation and policy is critically important in terms of addressing disparities. And that also relates to funding, because that's where the money comes from. It's the legislators. It could happen at the state level and it could happen at the federal level. And we need to support our president in terms of the Cancer Moonshot to make sure that that continues to live and exist and prioritize prevention and prioritize health equity and disparities, especially focus on our Black community.
Shelley, do you want to talk a little bit more about advocacy and policy?
Sure. Yeah, I wasn't aware of this bill in California. That's wonderful because we work mostly on the federal level. I mean, it's unfortunate that it's a burdensome process, but at least it's an avenue for people to get access to care. And there definitely have been plenty of studies to show that the Medicaid expansion through the Affordable Care Act had a huge difference in reducing mortality from cancer and reducing inequities. And unfortunately, there's some states that still haven't, taken advantage of that. I think, I know there's still some movement, but I think, I'm from Texas and I just don't see Texas ever expanding it, even though it would help save lives in their state. I just don't know that that's going to happen, unfortunately. I think Dr. Ashton, your point about the moonshot is really important too, because one of the things that, as part of the moonshot, I mean, they really are they call it an all-of-government approach and looking at where they can make a difference and looking at ways they can do it that doesn't require legislation, because in case you're not following Congress, they're a little bit dysfunctional these days and it's hard to get anything done. But for one of the things they did was include in the Medicare physician fee schedule this year, a proposal to pay for community health integration and I think I got that right. I know it was CH. Is that what it stands for? And patient navigation, basically, because patient navigation is something that can be really helpful to people going through treatment, but it's mostly funded by philanthropy. It's not reimbursed. And so this is a way for patient navigation to be reimburse a funding stream for that. And that has gone through. I mean, it was in the proposal for the physician fee schedule that came out this summer. Comments were due in September. I don't remember exactly when the final rule will come out. I think there were some there will be some challenges to implementing that, but at least it will give, cancer centers a way to actually get reimbursed for this thing that they've been doing when, cobbling together the resources to try to help people navigate the complex system and help them deal with some of the social determinants of health that they're dealing with, but they don't really have the funding stream for it. So I think that will be really helpful and important way to help fund that. And that's, I think directly a result of the president and first lady and their focus on cancer. And they think of it as, I heard the first lady speak a couple of weeks ago, and she talked about it as part of the moonshot, that they, were looking at ways that they can get things done through administrative means. So it's not always just about legislation, but there, how we pay for cancer care has a huge impact on how it's delivered. And so if we can find ways to pay for the things that are lacking in the system, I think that will be really helpful.
So before we move on to questions, and if anybody has any questions, please put them in the question and answer, and I'll definitely make sure to post to our panel. On this call is folks all over the country who are part of our Urban League affiliates, who are on the ground, trusted messengers, as Dr. Ashton was talking about, who are working with people every day. If there's one thing that they could do to help the communities they serve, when we're talking about whether it's cancer screening, treatment, or prevention, or outcomes, can you just say something you think that they could do now that could really help their communities in trying to really make sure that we get people as early as possible in getting cancer treatment and screenings? And anybody can take this, or I'd actually like all of you to take it.
Screening. So if they can work with faith-based organization, beauty shops, wherever people go, Black bookstores, there are a few of them that still exist. Cancer screening saves lives. And so in small groups, in large groups, developing webinars, just any way they can get the message out. Using Black radio, there's still Black radio, there's, Black newspapers exist all over the country. Put out ads for cancer screening, that it saves lives. Using survivor stories helps to, remediate the stigma and show that people are living and living well beyond cancer. But, using Black media outlet, whether it's social media or traditional media, newspapers, we still read those in the community. And working also with our FQHC, our federally qualified health clinic partners, I think would be a great way to touch and reach our community, because cancer screening does save lives.
Dr. Lawrence or Shelley?
Sorry, I've been going back and forth on what is like one thing, and I struggle. And honestly, I struggle with that because it's not just one, but it's not a lot. As mentioned by Dr. Ashton earlier, yes, working with your local community members from churches to barbershops to other gatherings to help provide resources to when it comes to screening, to informing on various cancer risk factors such as diet. That is important. That is needed, but it's not enough. You also got to speak to your representatives, your leaders, both from the local level all the way to the federal level, to advocate for more equitable policies that provide people with access to care and quality treatment. As mentioned earlier, we see that there is a policy, the ACA, where we see that states that did pass ACA, that did pass Affordable Care Act, they do, we see that cancer survival has increased compared to those that did not pass it. We see that among those that did pass it, there's been a shift to earlier stage diagnosis than later stage diagnosis compared to those that did not pass it. Among those that did pass it, we see that when it comes to that decision between seeking medical care from basic cancer treatment to either to access to groceries as well too, that decision between resources that juggling people often have to make is largely greater among states that did not pass it. When it comes to access to participate in clinical trials, we see lower income individuals in states that did pass it are more likely to participate in these clinical trials. So it's both at the local level when it comes to your policymakers to both on the federal level, as well as working within your local community. So I can't just say there's one thing. There's just so many, but these two areas, both working with your community within your community for cancer education, but also speaking to your leaders as well, to your representatives to help develop more equitable policy. Because at the end of the day, equitable policies helps everyone, not just one group, but everyone.
Mhm.
I would just agree with
Anything?
what Dr. Ashing and Dr. Lawrence have said. I mean, I think they've given some great examples. I agree that screening is kind of the first. If you can do one thing, that's the first thing. But I think to your point, Dr. Lawrence, there's so many different areas where we really need help. But I think, that the education and sharing of stories is so important to help people understand, and maybe also engaging young people to be to help with, to help them be ambassadors with their elders and their family, and because they're also caregivers to their older relatives, and trying to engage them.
No, Shelley, I actually think that's really, really great. And I want to go back to a point because I think you're making connected points that Dr. Ashing made about learning about your family history. Every medical student, I didn't go to medical school, but I have a sister who's a physician. Every medical student, one of their, at least I think back when she went to medical school, they make them do a family tree. And every medical student has to go and ask their family their questions and figure out how people, how older folks in their family, what they died of, whether it was old age, whether it was something, that's actually how we found out in our family that our grandmother, we didn't know. My grandmother died of cervical cancer, and I had no idea until my sister did this medical school kind of project and started asking our family, what happened. And so I think it's important to talk about the young people kind of asking questions and saying, well, what's going on in our family? What do we have, so that people are more informed? And also, so I think that's a wonderful kind of connection about the connection between your family history, but also the young people kind of helping people access resources also. And so going in this access resources, there is a question in the chat. And I think I can answer it also, but I'm going to ask the panel to answer it. Is, are you aware of any toolkits or existing materials or trainings that we can use to do outreach and education?
That's not my area of expertise, so I don't know.
So I think the first, go ahead, Dr. Ashing. Perfect.
Well, I was going to add the partnership with Urban League that we have with Anthem and Pfizer and City of Hope. It's the takeactionforhealth.org. So I have that in the slide, and so we can very much use that as a resources for cancer screening as well as other risk factors. So it has a mental health component as well. So takeactionforhealth.org.
Okay, we'll definitely make sure. We always send out the recording to our participants, and we also put it on our YouTube page, and we'll definitely make sure we put that resource. Dr. Lawrence, anything, and then I'll mention a couple.
That's mine. It's not my, unfortunately, my area of focus. So I can't recommend one right now at the moment.
Yeah, so what I would say is American Cancer Society has some really great toolkits and educational materials, and so does CDC, and actually so does NCI. So,
yes.
I was just going to say our federal partners and our associations have some really good toolkits. I'm going to assume, I don't know this 100%, it's probably mostly focused on breast cancer, but I'm sure that the Susan Komen Foundation has toolkits, also materials that will be out there. So several, I know the Colon Cancer Association also has materials. So some of the individual cancer societies will have it, but I will say American Cancer Society is probably your first resource, and then they will usually link you to other ones. And then a lot of the comprehensive cancer centers also have their own resources. So that's a good way to start. But I wasn't sure it was an anonymous question. I can't answer right now. But any of the affiliates who want questions, we can also work with you to find you local resources or national resources to expand this education. So I just wanted to say that. But that's a wonderful question about how do you get the education, make sure you're informing people in the right way. And so we have about 8 minutes left. I don't think there's another question, but I actually have another question for the panel, and I think we can close out in this question. Can you talk a little bit about the work you're doing now, and what's exciting you? What would you like people to know about what your organizations are doing, and whether it's research or advocacy work that you want to put out there into the Urban League universe and the universe in general? I'm gonna pick on Dr. Lawrence because he kind of started me off. Go ahead.
Yeah, so I'm a social epidemiologist by training. So a lot of my work seeks to understand the role the social environment contributes to cancer disparities. So a lot of my work is specifically on the neighborhood environment. So how does where you live, where you grow, where you age, how does that affect your risk of cancer or your risk of mortality? So that's a lot of where my work is. So I'm not in the population, I'm not in the public too much, but I'm more with working with large data sets to seek out why are certain populations at greater risk for developing cancer or have poor survival compared with other groups.
Well, I started out, my work in cancer started out as a child with having my father diagnosed, and then later my mother diagnosed with cancer, and have had several other family members. So it's been something that I have lived with as a researcher, but also as a caregiver and an advocate. So I consider myself as a scientist advocate. My training formally is in clinical psychology. So at City of Hope, I am Associate Cancer Center Director for Community Outreach and Engagement. So that entails basically what I do. I engage the community to influence the work that we're doing at City of Hope so that we're better responsive to the needs of our diverse community. I'm very passionate about community engagement and community activation and community capacity building. I think it's the only way we're gonna make a movement in terms of addressing disparities. How we translate the science and all of the advances that we're learning and benefiting from as a society, minorities as a society, including Blacks, are not benefiting in the same way. And so we have to engage our community leaders, activate our community leaders, educate our community members on how to be informed about their rights, about healthcare access as much as they can, their rights about voting to influence policy and legislation to better benefit our community, and to change communities. So if you have a lot of dedicated tobacco and vape shops in your community, there are actions that you could take. It's a long process, but that there are community organizations that work towards those, restricting, the proximity of these kinds of retail establishments to schools and other facilities, or housing, public housing or housing with multiple units. How can we reduce some of the toxicities or the whether it's tobacco related or living next to say an oil change place or something like that, how they dispose of those things. So all of these things are very much part of the work that I do. I learn from the community how they make changes, and have communities share resources, because some communities have a knowledge base about a certain type of advocacy that they can take, whether it's policy and voting and engaging legislators, or making changes within the schools. So it's about sharing the resources and knowledge, and together we could do better for our community.
And I would just
Go
like to
ahead,
say,
Shelley.
well, our state of survivorship survey is something that, I would be happy to, I can give you the resource, the link to it, Lydia. One of the things we did this year was we included a caregiver component. We surveyed 500 caregivers and asked them about their experience. And we use that data for so many different reasons. We share it with researchers. We use it to inform our policy work, our advocacy work. We share it with members of Congress. But a couple of things that we also do that I love, that I think, and you all, it may have, members or volunteers or people who work with you who might be interested in it. There are two programs where we really engage advocates to help improve cancer care. So one of them is our cancer policy and advocacy team. And and we have educational programming for them. We bring them, we have a conference in DC in June every year, and we bring them to DC. We provide scholarships to attend. We go to Capitol Hill, meet with members of Congress, talk about legislation related to cancer care and cancer survivorship. We've advocated for cancer care planning that Dr. Ashing talked about for very many years, survivorship care plans. And then another program is called Elevating Survivorship, and that's where we work with a small group of 10 ambassadors every year to do, and they're working on projects in their local community, and many of them, about half each year, are focused on health equity. So we have people working, like we've talked about, in Black churches to try to share information about screening and about survivorship, sometimes in an urban setting, sometimes in a rural setting. One of our Elevate ambassadors did a project in her community to educate older Black cancer patients about how to use telehealth, how to use the portal, how to even, I mean, some of them, she had to set them up with an email address and get them a tablet so that they could use it back during the pandemic when you really needed that for visits, but even just to use the portal to check test results or to communicate with your physician. She just kind of went hands-on to educate people who were really technology unaware on how to use that to support their cancer care. So we work with people and try to provide them technical support and mentoring on these projects that they're doing in their communities, based on what their assessment of the needs in their communities. And we have some really incredible advocates. So we put out a call for applications every year in the spring to bring on a new class of Elevate ambassadors. And I think it's a really great program. They've done some amazing things.
Well, as you can see, we have an amazing panel. I want to say there's one more question. It wasn't a question, it was more of a comment that came into the question and answer, and that I just want to address, and I think I can address it really quick because we're also at time, so I want to respect people's time, including our panel. Is one of our participants said, I'm a 5-year cancer survivor, and I don't feel like my physician still pays attention to the changes that are happening, in my life and with my medicine. And so what I would say is find a new physician. Find a new physician that listens to you, that understands you, that is willing to listen to what you have to say and work with you on making your life and your quality of life better. Physicians, they're humans, and sometimes it may not be the right fit. And doesn't mean they're a bad physician, it's just not the right fit for you. And so you should find a physician who's the right fit for you, who can help you navigate post 5 years dealing with your medication and whatever issues you're having.
And I just want to add, some oncologists are just really good at the treatment side of things and not as good at the post-treatment, the survivorship. And, maybe find a survivorship clinic. I would look for a nurse practitioner, frankly, because they really have more time to spend with you and can really help you navigate a lot of those side effects. I think nurse practitioners and PAs are really going to be the key to survivorship care, because oncologists really need to be focusing on those people, all the new people being diagnosed with cancer, and the nurse practitioners can help really look at how is this affecting your life. So that would be my advice. Agree with
Fantastic.
you.
Yeah, I think that's a wonderful way to end, that just always look for the resources that are best for you. I just want to say thank you to my panel. Thank you for all of you who are on the call. This was a wonderful educational opportunity, and I look forward to additional opportunities to talk about this topic. Have a great day, everybody. Happy Halloween.
Thanks
I forgot it's Halloween.
Thank you.
Thanks
for all that
Thank you so
everybody
much.
is doing.
Bye.
Thank you so much. Bye-bye, everybody.